Welcome everybody. Today we will discuss pulmonary hypertension in dogs. But first of all, thank you so much for being here today. Despite all the challenges that COVID-19 has brought to our lives, you had decided to spend this time with me. Thank you so much. To make your time worthwhile, I have spent several hours in this presentation with the hope that I'll be able to deliver some of the information that can be helpful to you in your practice. But let me introduce myself first. I'm Dr. Deepmala Agarwal. I have earned several degrees, including a DVM, a master's, and a PhD, only to become a veterinary cardiologist, which I hope to become one soon. But for now, I'm in second year of my cardiology residency program here at Atlantic Veterinary College, UPEI. I work with Dr. O'Sullivan and Dr. Cote, who are the cardiologist and my mentor, and Elaine, who is the nurse. These three people make the world's most wanted cardiology team. So I thank them for helping me with this presentation as well as for my cardiology residency program. Now let me ask you this. How many of you have seen a case of pulmonary hypertension? From here on, we'll call it PH. Good. It looks like most of you have. And for those who hasn't, I remember what one of my mentors always say, in quotation mark, I have not seen it, but I'm sure it has seen me. PH is one of those conditions that most, if not all of us would encounter many times in our career. So what is pulmonary hypertension or PH? In simple words, it's an abnormally increased pressure within the pulmonary artery or pulmonary vasculature. In more sophisticated terminology, it's a hemodynamic and pathophysiological condition, which is defined as an increase in mean pulmonary artery pressure of over 25 millimeter of mercury at rest, as assessed by right heart catheterization. We will discuss in detail some of the nuances mentioned in this sentence, but from this definition, you get a sense of one thing, that PH is not a disease. Rather, it's a pathophysiological condition that can be associated with several diseases. Now, it is important to recognize here that this is quite unlike systemic hypertension, which is defined as systolic blood pressure of over 150 millimeter of mercury and diastolic blood pressure of over 95 millimeter of mercury. So in next 45 minutes or so, I would like to discuss a little bit more about what pH is, what is the pathophysiological mechanism behind it, why should we care about it, meaning what are the consequences, what are the invasive and non-invasive ways to identify this condition, and then once we have identified it, what can we do about it. But before we go further, I would like to mention two quick things. The expected audience for this presentation are our budding veterinarians, that is preclinical and clinical year of DVM students, faculty, staff, and house officers working in small and large animal veterinary hospitals, and probably a few folks from human medicine. So by keeping this vast spectrum of audience in mind, I have included some basic concepts throughout my presentation just to bring everybody on the same page. And second thing is, if you guys have any questions, please feel free to raise your hands. Even though I cannot see you, at least you'll get some stretching, which is not necessarily a bad thing. Without further delay, let's get started. So while I do not want to bore you with the fundamental concepts too much, I would like to mention a few things that I wish I had understood really well when I was a student myself. So in this image here, you can see the heart in the center. There are four chambers in the heart, as you know: left atrium, left ventricle, right atrium, and right ventricle. When left ventricle pumps, it delivers oxygenated blood to the aorta, and aorta then supplies oxygenated blood to various parts of the body. Veins from those body parts drain deoxygenated blood into the right heart. When right ventricle pumps, it delivers deoxygenated blood to the lungs via pulmonary arteries. Oxygenated blood then drains back into the left atrium via pulmonary veins. So there are 3 points that I want to make here. One, there are two circuits here, as you can see. The systemic circuit that moves blood from the left side of the heart to the body and returns to the right side of the heart. The second is the pulmonary circuit that moves blood from the right side of the heart to the lungs and back to the heart. Second thing is, Lung and heart, as you can see in this figure, are very intimately connected with each other in such a way that a heart disease can affect the lung, and if there is a lung pathology, it can cause significant cardiac changes. And finally, the third point is, if you have noticed, the left and the right ventricle both eject essentially same amount of blood, which is a normal condition is about 3.5 liters per minute per meter square. But the blood that's ejected out from the left ventricle is being shared between several body parts, whereas the blood ejected out from the right ventricle has to go through only just one organ, lungs. And yet, the blood pressure within the pulmonary circulation is 5 times less than the systemic circulation. So, how is that possible that all the blood ejected out from the right ventricle is being carried out by pulmonary artery without raising blood pressure too much? Well, we'll get the answer of that question in just a minute, but here is a question for you. Can you think of a heart disease that can cause lung changes or lung problems? And for an extra challenge, can you think about a lung disease which can lead to secondary cardiac changes? Well, if you're listening to a recorded version of this presentation, you can pause if you need a little bit more time to think about, but here is the answer. Cardiogenic pulmonary edema is the classic example where heart disease can result in pulmonary changes, particularly pulmonary edema or pulmonary infiltrates. And nothing but pulmonary hypertension can be associated with a primary respiratory disease, which can then lead to secondary cardiac changes. And I have listed core pulmonary here, which I will not discuss, but that is for something for you to look at your home. Here is another question for you to consider that one of the students asked me a few months ago. Why we call pulmonary artery an artery even though it carries deoxygenated blood? Well, in this slide, you get the answer and also some other differences between an artery and a vein, which I leave for you to read yourself. All right, so let's go back to our original question regarding pulmonary artery pressure or PA pressure. The reason that pulmonary artery is able to carry a large amount of blood yet have less blood pressure is because of the anatomy of the pulmonary arteries. As you can see in this image, most of the arteries in the body, including pulmonary artery, is made up of 3 layers. Inner layer, middle layer, and the outer layer. Inner layer is called tunica intima, middle layer tunica media, and the outer layer is tunica externa or tunica adventitia. Tunica media is made up of smooth muscle cells, and both sides of this tunica media layer there is elastic tissue. In pulmonary arteries, there is a lot more elastic tissue compared to aorta and other systemic arteries. In addition to that, pulmonary arteries are thin-walled and they have large diameter compared to the counterpart systemic arteries. All of these attributes make pulmonary arteries more compliant, so they are able to handle more amount of blood without increasing blood pressure too much. Therefore, in summary, pulmonary vascular blood is considered a low pressure, low resistance, high capacitance system. In this figure, I'm trying to show you all the pressures associated with pulmonary artery. For example, the mean PA pressure normally is about 15 millimeter of mercury, and systolic PA pressure is about 25. Diastolic PA pressure is about 8 millimeter of mercury in normal condition at rest. And just to refresh on the definition of pulmonary hypertension once again, when mean PA pressure is over 25 millimeter of mercury, systolic over 30, and diastolic over 19 millimeter of mercury, that's consistent with pulmonary hypertension. All right, so based on the underlying cause, pulmonary hypertension has been classified in major 6 groups that are listed here. Those groups are 1. Pulmonary arterial hypertension, PH due to left-sided heart disease. Group 3, PH due to respiratory disease or hypoxia. Group 4, PH due to pulmonary emboli, thrombi or thromboemboli. Group 5, PH due to parasitic diseases. And Group 6, PH due to multifactorial or unclear mechanism. This classification scheme has been adopted from the human medicine, Within these groups, there are subgroups also, categorizing the underlying cause even further. That is available in this scary list. It is important for us to know these major groups and subcategories because the way you would choose to treat any individual patient would depend upon what is the underlying disease causing PH. Here is the good news though. If we understand a few other basic concepts, then that will help us nail all of these down without having to memorize any of that. So let's dive into it. Pressure in any system depends on two things, blood flow and resistance. For example, if you have a tube, let's say you have an IV catheter, the flow through that catheter will depend on the pressure difference between the two ends of the catheter and the resistance to blood flow. This law is called Ohm's law, and it can be applied to pretty much any kind of blood vessels or a tube. In fact, this is the same law that applies to flow of current, where current equals to voltage difference divided by impedance or resistance. So if we apply the same concept to pulmonary vasculature, this is how it will look like. The blood flow through the pulmonary circulation here or pulmonary vasculature will equal to the pressure difference at two ends of this system. At one end, you have pulmonary artery pressure. At other end, you have pulmonary venous pressure or left atrial pressure. So now you'll have pulmonary blood flow equals to the pressure difference between mean pulmonary artery pressure and mean pulmonary venous pressure divided by pulmonary vascular resistance. So now, knowing what we know so far and looking at this picture here, can you think of a disease condition where pulmonary blood flow will increase? Meaning the flow through these pulmonary arteries will increase. Well, if you're thinking about an intracardiac shunts, you are correct. So in any kind of left to right intracardiac or extracardiac shunt for that matter, for example, atrial septal defect, ventricular septal defect, or patent adductus arteriosus, all of these conditions will result in increased pulmonary blood flow, and that can affect the pulmonary artery pressure. Now, the second component of this equation is pulmonary venous pressure. So can you think of a disease condition that will result in increased pulmonary venous pressure or left atrial pressure? Well, you are right that left-sided heart disease, if it results in enlargement of left atrium, that will cause increase in left atrial pressure and in turn increased pulmonary venous pressure. Now, final component of this equation is pulmonary vascular resistance, and this one is a tough one. Pulmonary vascular resistance or PVR can be explained by Poiseuille's law. This whole thing and all these equations associated with pulmonary vascular resistance was so difficult for me to understand until I made some drawings, even though I'm not an artist. I'm going to show you a pair of tubes with the different dimensions. And if you have to think about which tube will allow faster flow, for example, here you have two tubes of same length, but one is wider and one is less wider. If you have two tubes, same diameter but different length. If you have two tubes of same diameter and same length, but for one I give you 1 liter of water to flow through it, and for one you have 1 liter of tomato ketchup. Now you have two tubes of same length and same diameter, but one tube is corroded from inside and even has a clog inside. Great. So you are right that the tube which has smaller diameter, which is longer, through which you have to pass the tomato ketchup instead of water, and the tube that has corrosion inside or clogging inside would have high resistance to liquid flow or blood in this case, and will have lower flow rate as opposed to the other situations here. So you have just derived the Poiseuille's law. Out of several factors that we have just discussed, the vessel diameter is the most important because resistance is inversely proportional to the radius to the fourth power. That means a twofold increase in radius will decrease the resistance by 16-fold and vice versa. So I never remember this equation, but when I think of these tubes, everything makes great sense. Alright, so let's look at some of the examples where you would encounter high resistance situations in pulmonary vasculature. The diameter of the pulmonary artery would be affected by vasoconstriction and vasodilatation. There are two conditions that you should remember that cause vasoconstriction in pulmonary artery. One is hypoxia and other is left-sided heart disease, and I'll show you that in just a minute. The situation of tomato ketchup will come if there is a hyperviscosity of blood due to polycythemia or leukemia. And then by this kind of drawing where the internal the vessel is damaged and is clogged can happen because of infection, inflammation, or thrombus formation, or for example in heartworm disease. So as I mentioned, the vasoconstriction in pulmonary vasculature can occur due to hypoxia or left-sided heart disease, especially with the left-sided heart disease when there is an increase in left atrial pressure that causes reactive pulmonary artery vasoconstriction because of passive transmission of left atrial pressure. And here is an example of heartworm disease resulting in arteritis and causing thromboembolus, resulting in pulmonary hypertension. This image here is showing the heartworm worms present in the pulmonary artery. Here, the pulmonary artery has become very thick and damaged due to the inflammation. This is the histology image showing the narrowing of the pulmonary artery lumen due to the proliferation of the inner layer of the artery. So I hope now you don't have to memorize this list because now you understand how these diseases will result in pulmonary hypertension. Now I want to make a few important points about all of these groups. So for pulmonary arterial hypertension group 1, cardiac shunts are one of the causes, but other than that, it can be idiopathic, meaning the underlying cause may not be known, could be heritable, or could also occur because of drugs or toxins. For group 2, PH with left-sided heart disease, pretty much any left-sided heart disease can result in pulmonary hypertension, but myxomatous mitral valve disease is the most common cause. Similarly, any pulmonary disease can result in PH, but some of the common conditions that we see in practice are chronic obstructive airway disease because of tracheal or bronchial collapse, or primary pulmonary parenchymal disease such as interstitial pulmonary fibrosis in West Highland wheat terrier and pneumonia. And then there are some other causes that are more common in human medicine, but we also see in canine medicine as well. Here is the list of diseases that can predispose our patients to a thromboembolic condition. Most important in dogs are hyperadenocorticism, immune-mediated hemolytic anemia, neoplasia, and protein-losing diseases. Now, regardless of the underlying cause, when pulmonary hypertension persists, it leads to unwanted vascular and cardiac complications. For example, due to shear stress and high pressure, pulmonary arteries may develop hypertrophy of the tunica media, fibrosis of tunica intima, resulting in vasoconstriction and inflammation, leading to obstruction to blood flow. These changes may lead to what's called pruning of the pulmonary arteries. In terms of cardiac complications, when pulmonary artery pressure increases, it causes increased load on the right ventricle. As a result, right ventricle adapts by increasing muscle contractility and increasing wall thickness. Over time, to maintain cardiac output, right ventricle dilates and it starts pushing the intraventricular septum towards the left side. And finally, in more advanced cases, this condition may result in right-sided congestive heart failure, resulting in ascites and pleural effusion. In humans, a bunch of other complications have been reported as listed here for your information, but what got me most excited was this: cardiovocal syndrome, resulting in hoarseness in your voice. If you are as curious as I was, look this up, but here is a hint for you. All right, so now we have understood the possible causes for pulmonary hypertension and what's the definition in pathophysiology. The next question is how to diagnose these patients or how to identify these patients. So, well, just like any other disease conditions, signalement, clinical signs, and physical examinations are the key to diagnosis of pulmonary hypertension as well. So in terms of signalement, middle to older age small breed dogs are most commonly affected simply because they are the ones who are predisposed to some of the conditions that are associated with pulmonary hypertension, such as left-sided heart disease and respiratory disease or hypoxia. So for example, West Highland Wheat Terrier and Pekingese are the breed at risk for pulmonary fibrosis. Similarly, these are the breeds who are predisposed to left-sided heart disease as well. But you will see pulmonary hypertension pretty much in any dog breeds of any ages. Now, in terms of clinical science and physical exam findings, according to the current guidelines that we have in canine regarding canine pulmonary hypertension, clinical findings that are most strongly suggestive of pulmonary hypertension include syncope without another identifiable cause, respiratory distress at rest, and right-sided heart failure. In one study, syncope and cough has been shown to be the most prevalent clinical signs in respiratory-associated pulmonary hypertension. However, while these dogs may present to you with any of these signs, they most often present with the signs of primary disease, such as honking cough due to tracheal collapse, crackles due to pulmonary fibrosis, and in advanced stages, they may even have signs of right-sided heart failure, such as ascites, pleural effusion, jugular venous distension, and so forth. And here is the interesting thing. In one retrospective analysis of 201 dogs, the authors have shown that a stronger right-sided than left-sided apical murmur has a positive predictive value of 83% and a specificity of 96% for diagnosis of pulmonary hypertension. When they combine right-sided murmur with syncope, the positive predictive value increased to 92%. So watch out for right-sided heart murmur in these patients as well. All right, in terms of diagnostic test, direct pulmonary artery pressure measurement via right heart catheterization is considered the gold standard for diagnosis of PH. This is performed with a specialized catheter named Swan-Ganz catheter that's positioned within the pulmonary artery via jugular vein or femoral vein approach. We will not go in detail about the right heart catheterization, but just so that you know that's the gold standard. However, as you can imagine that procedure is an invasive procedure. It requires general anesthesia. It must be expensive, and it does not come without any complications. So there are some other non-invasive tests that we can utilize for the probability assessment for pulmonary hypertension. And one of the most important one is echocardiography. Now, echocardiography is a tool that allows us to obtain an indirect estimate of PA pressure in dogs who have tricuspid regurgitation or pulmonic regurgitation. The tricuspid regurgitation is the backflow of blood from right ventricle to the right atrium. And pulmonic regurgitation is the backflow of blood from pulmonary artery to the right ventricle. By measuring the velocity of any of these regurgitant jet, we can get a rough estimate of PA pressure. Fortunately, a certain degree of tricuspid and pulmonic regurgitation is frequently observed in most of the patients, so we can get an estimate of PA pressure. However, other than measurement of PA pressure, echocardiography allows us to look for other signs of pulmonary hypertension as well, such as right ventricle hypertrophy or right ventricle systolic dysfunction, pulmonary artery enlargement, right atrial enlargement, and in some instances, we can even look for enlargement of caudal vena cava. Here is an example. These are the transverse images from normal dogs on the right side panel and a dog with severe pulmonary hypertension on the left side panel. You would see left ventricle in the center and right ventricle as a crescent-shaped structure on the top of the left ventricle and interventricular septum in between. If you compare both images, you can appreciate the flattening of the interventricular septum in this dog, which is due to increased right ventricle pressure secondary to pulmonary hypertension. Similarly, here is an echo image showing pulmonary artery dilation in a dog with severe pulmonary hypertension on the left panel here and normal sized pulmonary artery on the right panel for comparison. In both of these images, aorta is in the center here and the pulmonary artery and two branches are here. Normally, pulmonary artery to aorta ratio should be 1:1, but here you can say that's definitely not the case. Other than making a diagnosis of pulmonary hypertension, echocardiography allows us to rule in or rule out some of the underlying diseases that can cause pulmonary hypertension. For example, here is a echocardiogram showing left atrium to right atrium shunting of blood, so the intracardiac shunt in a dog who had pulmonary hypertension. In this image, the dog had severe myxomatous mitral valve disease, as you can see by looking at the thickening of the mitral valve and the prolapse of mitral valve. And in this dog, left side heart disease was the primary underlying cause for pulmonary hypertension. Alright, so the next modality is thoracic radiography. The classical radiographic signs of PH that you will find in textbook are right ventricular enlargement, as often described as reverse D pattern in VD view, main pulmonary artery dilatation, and enlargement of lobar pulmonary arteries. In a recent study, it has been shown that right ventricular enlargement and main pulmonary artery dilatation has 91 to 100% specificity, although the sensitivity was only 48 to 64%. Meaning, if we see main pulmonary artery dilation and right ventricular enlargement, it's very likely the patient has pulmonary hypertension, but if we do not see it, it cannot rule it out. And we also need to understand that both of these changes can occur secondary to other diseases such as pulmonic stenosis or heartworm disease. Similarly, the utility of radiographs in differentiating different degrees of pulmonary hypertension is very little as well. Chest radiographs can be very critical in ruling in or ruling out several underlying disease processes that can be associated with PH in any patient. For example, here is the chest radiograph from a dog who had severe pulmonary hypertension due to bronchopneumonia, and that can be seen on this radiograph. On the other hand, this particular dog, on the radiographs, we did not see any evidence of neoplasia, no evidence of pneumonia or left-sided congestive heart failure, yet this dog had severe PH. These radiographs show ruled out bunch of the diseases in this dog resulting in PH. In this particular radiographs, we can see evidence of left-sided congestive heart failure characterized by severe cardiomegaly or cardiac enlargement, pulmonary venous dilatation, and left atrial enlargement, as well as mild bronchointerstitial pattern suggesting pulmonary edema. In terms of CT scan or a computed tomography, for especially focusing on chest, it's a highly sensitive imaging modality. Similar to chest radiographs, CT is very helpful in ruling in some of the primary respiratory diseases that may be less obvious on radiographs. For example, here is a thoracic CT from a 13-year-old soft-coated Wheaten Terrier showing marked dilatation of the medium and small airways, that is bronchiectasis, involving the left and the right cranial lung lobes here. Bronchiectasis is one such finding that's sometimes not very obvious on thoracic radiographs. Similarly, this is a CT pulmonary angiography, which is particularly useful to confirm a diagnosis of pulmonary thromboembolism in small animals, as can be seen in this image from a 7-year-old American Staffordshire Terrier with pulmonary hypertension. In terms of cardiac biomarkers or blood test, cardiac troponin I and NT-proBNP has been investigated. And as you can see in this graph here, cardiac troponin I was not helpful in differentiating between dogs with respiratory disease with PH versus respiratory disease without PH. Similarly, NT-proBNP was not specific enough to discriminate between dogs with myxomatous mitral valve disease with or without pulmonary hypertension. All in all, cardiac biomarkers are not helpful in diagnosis of pulmonary hypertension. Preliminary blood work, including CBC and chemistry, can be very helpful in ruling out conditions such as polycythemia, leukemia, and some other systemic diseases. So by now, if we have found an underlying disease that we believe is likely responsible for PH, treating that would be the most fruitful and logical approach. We will not discuss the treatment options for all the underlying diseases because that probably requires not one, but several talks of its own. However, in all patients with pulmonary hypertension, regardless of the underlying cause, there are some recommended strategies to decrease the risk of progression or complications. These are based on common sense. They are not tested in randomized clinical trials yet. For example, in the current guidelines, it's recommended that intense exercise should be restricted or avoided. Patients should be vaccinated for contagious respiratory pathogens. Chemoprophylaxis should be considered for heartworm disease, and pregnancy, high altitude, and air travel, as well as general anesthesia for elective procedures should be avoided too. Now let's talk about pH-specific treatments. pH-specific treatments specifically target one of the cellular pathways that are involved in pathogenesis of pulmonary hypertension. We will not go in detail about these pathways, but two important things to note here. There are three substances that play a big role in pathogenesis of pH. Those are endothelin, nitric oxide, and prostacyclin. Among these three, endothelin is the only one that has vasoconstrictor properties, whereas nitric oxide and prostacyclin are vasodilatory. In the setting of pulmonary hypertension, endothelin level goes up and nitric oxide and prostacyclin level goes down. So you can imagine that for the treatment of pulmonary hypertension, we would need to block the endothelin pathway. That means using endothelin antagonist, or we will need to increase prostacyclin pathway by using prostacyclin analog. And then if we could, we would want to increase or activate the nitric oxide pathway by using a medication that comes under phosphodiesterase 5 inhibitor category. And I'll tell you a little bit more about that. Among these, for endothelin antagonist and prostacyclin analogs, there are no clinical trials in naturally occurring disease in dogs. Those two classes of medication are more commonly used in human medicine. For us, the only one that we have for veterinary use is phosphodiesterase 5 or PDE5 inhibitors, such as sildenafil, tadalafil, and vardenafil. These PDE5 inhibitors potentiates nitric oxide pathway by inhibiting the breakdown of cyclic GMP. Sildenafil is the prototype and is the most commonly drug utilized in veterinary medicine. It's a short-acting PDE5 inhibitor, and it has been shown in several studies that while the treatment with sildenafil does not affect the PA pressure that much, patients often feel better. So there is a clinical improvement independent of any changes in estimated PA pressure. In fact, in one recent study involving 39 dogs with group 3 pH, meaning pH due to respiratory disease, it has been shown that patients on sildenafil are 4 times more likely to survive than those that were not treated. So the question comes that when to use sildenafil in veterinary medicine. And I have prepared this table here to summarize some of the guidelines or some of the recommendations that are mentioned in the current guidelines. However, it's important to recognize that there are several exceptions to the rules that I'm going to show you here. Overall, sildenafil or pH-specific therapies are recommended for group 1, group 3, and group 4 diseases as listed here, with some exceptions. For group 2 diseases, pH associated with left-sided heart disease, sildenafil is not recommended as first line, but it can be used as adjunctive in some cases. For parasitic diseases, specifically for diarrhea, sildenafil has not shown to have any effect on survival. And for angiostrongylis, it may be considered if there is no other underlying cause or underlying or associated conditions. And then if the patient has multifactorial or unclear mechanism associated pH, then we will have to take several things into account in order to make a decision about whether sildenafil is recommended or will be useful or not. In terms of prognosis, prognosis in dog with pH is very variable depending upon the underlying cause. In one older study, the median survival time was found to be very low, anywhere between 3 and 91 days from diagnosis. However, in a more recent study involving 25 dogs with respiratory associated pH with the sildenafil treatment, 50% survival of 6 months for all dogs was noted, and 4 dogs actually were alive 5 years after diagnosis. And in a study published last year, overall median survival times in dogs with group 3 pulmonary hypertension treated with sildenafil, the median survival time was 276 days. And they have also found that the dogs who have pulmonary artery pressure more than 47 millimeter of mercury had lower median survival time compared to those whose PA pressure was less than 47 millimeter of mercury. Great. So I think I have covered everything that we had intentions to cover. The definition and the pathophysiology of pulmonary hypertension, what are the consequences for it, how to diagnose, and what are the treatment options available. Now, in next few minutes, I'm going to show you 3 case scenarios just to kind of practice how to use the information that we have just learned into real life scenarios. So case number 1. An 8-month-old male intact Irish wolfhound presented to his primary veterinarian with the major complaint of acute onset tachypnea and dyspnea. On the chest radiograph, when they performed first, they had suspected left-sided congestive heart failure based on cardiac enlargement and some pulmonary infiltrates. They hospitalized the dog overnight on furosemide, but dog did not have any improvement. So he was referred to Atlantic Veterinary College for further workup. When he presented to us, due to suspicion for left-sided heart failure, he got an echocardiogram done. On echocardiogram, we were able to rule out any significant left-sided heart disease that would result in pulmonary hypertension. However, what we found was this. His pulmonary artery was very big, and there was flattening of the interventricular septum. He did not have any heartworm in his echocardiogram, and this is how his radiographs look like. So based on this information, can we try to answer some of the questions? I'm going to give you the answers here, but if you like to pause your video and think about it yourself, I think that would be very reasonable. So in this dog, cause for pulmonary hypertension was actually group 3 disease, which is respiratory disease or hypoxia. Now, this dog was very young, so it's possible that he also had an idiopathic component, which means group 1. And in combination, could this be a multifactorial process, possibly? Was his clinical signs primarily due to pH? Probably not by pH itself, because this dog had very severe bronchopneumonia. So it's possible that the bronchopneumonia was the main reason for his clinical signs, but pulmonary hypertension must have contributed to it. Whether to treat or not, because it's a group 3 disease, the sildenafil would be recommended in this dog. Well, this dog had some improvement initially with the treatment of his primary disease, bronchopneumonia, and sildenafil, but a month and a half later, he developed cor pulmonale. And remember, cor pulmonale is a thing that you have to look up by yourself. Second case. Here is a 14-year-old spayed female poodle cross who presented to our emergency clinic with the history of recurrent collapse episodes. Now, this dog had also had a history of presumptive tracheal collapse and chronic cough due to suspected chronic bronchitis. In our emergency hospital, this dog had a very thorough workup, including CBC chemistry, chest radiographs, urine analysis, and ECG, and no cause of her collapse episode were found on any of these tests. On echocardiogram, she did not have any significant left-sided heart disease, and her pulmonary artery was dilated, as you can see in the echo image here. So with the information that we had so far, we thought the cause for her pulmonary hypertension was group 3 disease again, possibly due to chronic bronchitis. Her clinical signs of collapse were very likely due to pulmonary hypertension because there was no other identifiable cause for her collapse episode. The treatment with sildenafil will be recommended for this dog because she falls under group 3 disease. Now let's look at the final case. This is a 7-year-old spayed female Havanese who presented to us for tachypnea and dyspnea. On physical examination, this dog had a very loud heart murmur, and based on the chest radiographs and echocardiogram, This dog was diagnosed with severe myxomatous mitral valve disease, resulting in congestive heart failure and also secondary mild to moderate pulmonary hypertension. So, cause for her PH was group 2 disease, which is PH related to left-sided heart disease. Her clinical signs of tachypnea and dyspnea were unlikely due to PH because it was only mild to moderate, and congestive heart failure itself can explain most of her clinical signs. However, PH may be a contributing factor. Since this dog has group 2 disease, sildenafil is actually not recommended for this dog. Rather, the treatment of the primary disease would be considered first, which is what was done in this dog. So with this, I would like to conclude my presentation. And for those of you who have my email, please feel free to drop some questions if you have, or comments or feedback. But for those of you who are seeing this video on YouTube, feel free to comment using the comment box below. Thank you so much for your time and your attention. I really appreciate it.